everybody, you Progress Report fans, you legions of folks out there. Here we are. We are now past the midpoint in February, and so we're on with another edition of the Progress Report for this Wednesday. And today we are very pleased to have, as I always am, except of the first Wednesday of the month, my good friend Mike Farley with me. He's available via Skype. Hi, Mike.
Good to see you again, Bob.
Good to see you. I'm looking forward to your return in person, but I hope that
Me
won't
too.
be
I
too
can't
long
wait to
delayed.
get out of this cave. I feel like a bear that's been in hibernation for a whole year. a lot of pent up energy. I don't know what's going to happen when I can get break free of this.
Hey, speaking of that, there's a new book out I just got called "A Libertarian Walks Into a Bear." Have you heard about that?
Yes, in fact, you promoted on the show. You spoke very highly of it.
Well, now I got to finish reading it. My wife read it. I got to get it to you. You'll get a kick out of it. So there you are. And we're very pleased to have back Phil Alexakos, who was the Chief Operating Officer for the Manchester Department of Public Health, one of two cities, two municipalities in the state of New Hampshire that has a Department of Public Health, and it's a damn good thing we do, because we certainly have got public health issues. Phil has been with us on a couple of prior occasions, and every time it's been very rewarding to get the information he's got, and he is also joining us on Skype. And I'm in the studio, folks, as you could probably tell, and I come in here because I'm hoping I'll be able to field some calls from people. 640-3091. You want to participate in our discussion? We would certainly be glad to welcome you, because we really appreciate having callers. They add a lot to the show, even though we may not agree with what they want to say every time.
Bob, this is the kind of show where it's a good opportunity to call in, because we've got the kind of guest that's got his finger on the pulse of something that's really important going on right now. So
Right.
A lot of practical questions, a lot of decisions to be made. So I'd encourage folks to call in too. Don't make Bob go all the way downtown in vain. Make him pick up the phone.
Right. Okay. So, folks, that's what we got up for tonight. Phil, I got a bunch of notes here I want to ask you about. It's not in any particularly organized fashion, and Mike always is great about chipping in. I thought I might start off by telling a little personal story from today, Mike. I'm a 1B guy. I am well past the minimum age to being in 1B. I'm well past that age, Phil. And I finally got my reservation, schedule appointment, and it's not till March 31st, which I was quite disappointed in. I would like to be in the line to get the first shot of my arm well before that. So I heard from a friend, Mike, Dan Caligari. I think you probably know who he is.
I do.
There was a chance I could go up to SNU University, which is administering vaccines, bring my registration with the logo and my ID, and get a shot, because he did it. So you're going to like this, Mike and Phil. So I went up there with my wife. I had my thing, and this nice young man with the National Guard was there, and he poked his head in. I showed him the thing, and he said, and I said, I got my ID. He said, okay, fine. And then my wife popped up from the passenger and said, I just think he should know that our reservation is for March 31st. And the nice young National Guard says, well, I'm not sure. I'll have to ask somebody over here. And he went over to somebody else, and he came back. He said, I'm very sorry. We can't take you here. And then he had to provide a whole, move a bunch of cones so we could exit out of the waiting line. So that was disappointing. That was very disappointing. And, my wife is honest to a fault. Honest to a fault. So
there's nothing better than an honest wife, though, Bob. So really, don't complain. Such troubles to have. Bob, can I jump in here, because I've been wanting to correct something. You may recall a couple weeks ago I was talking about the number of vaccinations per day that we would need to, or per week that we would need to accomplish in order to get herd immunity by this year, given the fact that we need 70% of a population of 350 million, and everybody's got to get 2 shots. And I was talking about 3 million shots. And then I got cold feet. Remember, Bob? I got cold feet, and I backed down. I said, I think my decimal must be wrong. Well, I checked it. We have to be at 3 million shots a week. Correct me, is it a week or a day? But basically, we're only at half where we have to be in order to get this accomplished by the end of the year, Phil. Can you talk a little bit about that? I know there's improvements. We're getting 57% more vaccine. They're cranking it out. They're ramping it up. But the goal is what? And I think you nodded your head when I said 3 million. I think that's where we need to be, isn't it?
Yeah, so you raised some really good points. Just looking at the different phases, when the state put out its most recent delineations of phase 1A, 1B, 2A, 2B, etc., they have a ballpark estimate. And so even within the 1B group, that's about 325,000 people. And just doing the math with that group, with the pace of vaccine at the time being about 17,000 doses a week, was going to take us well past March. But I do have information that there are increases in the allotments being given to states, which is part of that production ramp up that you talked about. There is some encouraging news with regard to Johnson & Johnson's pending vaccine review. They've submitted for emergency use authorization, and one of the clinicians that I look to for information, who's the dean of the Brown School of Public Health, has looked at some of the preliminary data, and even though the data doesn't suggest that it's 95% effective, we have to be mindful that that particular vaccine was tested geographically in a different manner than the other two vaccines, in that it was tested in South Africa and it was tested in places where these variants have cropped up. So even though it doesn't have that 95% protection estimate, it was also tested in places that had those variants circulating. The encouraging news about the Johnson & Johnson vaccine from the preliminary data is that it is very successful in preventing moderate to severe illness, similar to Pfizer and Moderna's vaccine. So even though there, 67%, efficacy rates are being cited, that takes into account those variant strains based on where it was tested, and it is very successful, comparable to Pfizer and Moderna, in preventing serious and moderate illness. And ultimately, like any viruses, they are going to shift and drift and change. If we can prevent serious and moderate illness, we're going to make sure that our healthcare system doesn't become overwhelmed. And if we can prevent mortality, I think that's our ultimate end goal, is to make sure that those outcomes don't happen. And so by getting additional streams of vaccine into the queue, so to speak, we should be able to get closer to that goal of 70, 80, even percent of a vaccination status, is what we're seeing for estimates for being effective and getting to that so-called herd immunity. So there are encouraging signs with regard to vaccine approvals for this new vaccine from Johnson & Johnson. It's also a one-dose vaccine, so it may be especially helpful in populations that aren't very good at coming back for a second dose.
Right.
So we hope to have some, good information about approvals by either the end of this month or the beginning of March, which may coincide with opening up to phase 2A and then beyond. What I don't know at this point is whether or not that vaccine is going to be approved for people less than 16 or 18, which is a limitation in the current state of things, where even if we do all of the adults that are eligible through the summer, we still don't have a vaccine that's approved for children under the age of 16. So I'm hopeful that we'll start to have some of those questions answered. And I think the bottom line is, regardless of vaccination status, because of these variants and other things, I don't see the common sense measures of face coverings and social distancing going away, magically when we, reach a certain phase I think that they're effective. I think that's demonstrated in the fact that our flu numbers are way down as compared to any other year where we typically will see flu activity. And for people who are saying, well, we're only testing for COVID, that's not necessarily true either. Any tests that we're doing are now being run flu A, flu B, and COVID, as do many of the healthcare partners. So it's not that we're not looking for the flu. I think we're doing a very good job with all of these prevention measures, which are effective against any type of respiratory transmission. So these are all good things, and I'm glad to be on with you to start to talk about this.
Yeah.
Because our data suggests that we are coming off of the post-holiday surges. Our hospitalization numbers are down. Our case numbers are down significantly from November, December, and January. They still are higher than the spring and into the summer, but they are trending in a good direction. And
Phil,
whether or not,
I want to stop you there because that is great news. We've had a couple peaks before where we've started to turn down, and they look very, very low from the summit we're on right now. I began the show kind of a little tongue-in-cheek saying, I can't wait to get out of my cave. And, when people hear that it's turning down and we have a vaccine and it's getting out, isn't that the time to redouble your effort so that you're not the last guy to die in this war?
Yeah, I mean, I think the key thing, as much as we're all very fatigued, there are some pockets of normalcy as we try to smartly reopen to pre-COVID times, but taking big steps. I know some states have let their mask mandates expire. It'll be very curious to see what the after effects are in those states. To your point, you don't want to be the last one to do something, but I wouldn't want to be the last one to not be using public health prevention measures. I'd rather be erring on the side of common sense. It's not like we're asking, putting on a face covering is inconvenient, but because we have to deal with the nature of things and viruses, it's helpful against all respiratory viruses. So whether it's COVID, whether it's influenza, whether it's RSV, which is another one that can affect the very young, especially, these just wearing a face covering does work. I think that science was unfortunately debated way too much. The more layers, the better. Really common sense stuff. And quite frankly, it's winter, so having an extra face covering isn't the worst thing in the world. So, from that standpoint, we were out snowshoeing, trying to be active in a safe way, and wearing a face covering was great, and you probably would wear one anyway. So, while we're in this season, it's not that much of an inconvenience. As we get closer to spring and the weather turns, we experimented, I know, in many communities with outdoor dining and really doing things differently. I think people can look forward to that as we get a little warmer. And hopefully by that time, we can start to have discussions about what makes sense from a public health standpoint and scaling back toward, pre-COVID.
Phil, you brought up a piece of data I had not been aware of, but I think it's very important, and that is the low incidence of sort of ordinary year by year flu. I had not heard that before, but we have a call. I'm happy to take our call. Hello, caller. Glad to welcome you to the Progress Report. You're on.
Yes, hi. Good evening. I have a question for all of you, and I don't want to sound off the rail here, but when the governor issued his executive orders in response to this COVID pandemic, and he issued the mask mandates, which your guest is addressing at this time.
Yes.
There was a medical exemption that was put into his executive orders because there are people that have certain conditions whereby they cannot wear a mask. And at first, those medical exemptions were accepted, and if you went into some place and they said, do you want to wear a mask, and you said, I can't, I have a medical condition whereby I cannot wear a mask, they were okay with it. Now the cities and towns have passed these ordinances. It doesn't matter where you go, and the Attorney General has been fining businesses for not requiring everybody to wear a mask. And this greatly concerns me because I don't think it's a one size shoe fits everybody. And I just would like to hear what you have to say about this.
All right, well, that's a very interesting point you brought up. I wasn't aware of that. I have no idea whether there's any significant number of people in that category, but I guess there must be some. Phil, what do you have to say in response to our caller's question?
Sure. Thank you very
I'll
much.
listen. I'll hang up and listen. Thank you for your program.
Well, thank you for calling us.
Yeah, thank you very much for calling. Certainly, any type of ordinance related to mask mandates, if you will, do need to consider medical issues that may preclude people from wearing them. Depending on, I know that when Manchester was considering a mask mandate, we were considering provisions to look at very young folks that may not be able to wear them or other issues. With the Americans with Disabilities Act, generally, if people have a medical accommodation, you can ask them certain questions, but you can't go into great detail. My understanding is that the Attorney General's office has put out several briefings for businesses on how to and what the extent of their ability to talk to people about mask use. So I would direct anyone who's listening to go to the Attorney General's webpage, and you can probably go to the governor's webpage, and there are links to some of those pieces around mask coverings. But generally speaking, there are exceptions for medical reasons, and getting into a debate with folks about whether or not that's appropriate or not is not generally a good idea. But then again, you're absolutely right. There are some establishments that have been fined by the Attorney General's office or the Department of Justice. I think it's the Attorney General's office. But I want to make it clear that any of those types of actions are not taken as one-offs. They are generally done, to my knowledge, based on our interactions with different businesses and educating folks for repeat, flagrant disregard for even requiring or providing face coverings. It's not a situation like this. It's a persistent, multiple offense type scenario. So I don't want any viewers or listeners to think that if you're caught once doing something and it may not be anyone's fault, or it may be a training issue, there aren't fines being levied on a one-off basis. They are persistent, multiple offending type situations. I know that to be true.
Phil, I wanted to ask you, the Manchester Department of Public Health, what is your role in getting the vaccines into people's arms? Do you actually have a role in that, and what is it?
So yeah, thank you for that question. It's probably been the happiest month. My last month working in public health has been dedicated to planning and organizing and conducting with our partners clinics. I want to first of all say that the National Guard does not get enough credit for the amazing work that they're doing.
Yeah.
Not only around running these vaccination sites, but they were instrumental in helping and assisting with testing operations, as well as setting up makeshift hospitals across the state. And we have been partnering with them since March on all of those fronts.
Phil, if I can jump in, down to the most simplest of things, I went and it was a National Guardsman that handed me a case of masks so I could, my company could stay open because you couldn't get them. I mean, right down to the basic nuts and bolts, and they were awesome about it. Very efficient, and the most efficient people you want to work with. They were great.
Absolutely. It's been an absolute pleasure to work with a whole host of different professionals from different disciplines that are serving their state and country. And without them, this would be a very, on top of a very difficult situation, even more so. So our role, anyone who has been able to fall into either 1A, which are first responders, folks in long-term care, employees in long-term care settings and healthcare settings, either received vaccine through their employer initially, so the hospitals did some levels of clinics, but smartly we wanted to consolidate and conserve resources with a very limited vaccine supply. So instead of having every hospital and every healthcare system do 20-dose, 30-dose clinics, centralizing and coordinating in a regional basis made a lot of sense, and still does for that matter. Our role has been working with our regional healthcare partners to help either staff and augment the kind of supersizing of these sites. So if you had gone to the site in Hooksett, which is the SNU site campus, they started out by doing a few hundred people a day, and now they're pushing 500, 600, 700 a day with more vaccine. And they are actually maybe even outgrowing that space and maybe looking at other campuses to kind of supersize even more so the maximum amount of throughput, we call it, to get folks through in a given day. Our role in public health is slightly different. We see ourselves as trying to fill the gaps. And the way that I use their term gap is, we're always looking at what's called the social determinants of health, things that get in the way or barriers or things that make it so that people can't attain their optimal state of wellness. Some of those things are transportation. Some of those things are functional mobility, language differences, other types of impairments that make it more challenging for folks to avail themselves of one of these fixed locations. So what we did early on is we reached out to several of our community partners that serve populations within 1A and 1B that maybe would require either more resources and transportation resources or translation services, and work with them to get to those folks. So we've been working with the Moore Center, which works with intellectually disabled individuals and their caregivers. Some of those are in residential settings, some of them are in group settings, with Easter Seals, which has a whole cadre of different services that they provide, as well as the Mental Health Center of Greater Manchester, as well as Manchester Housing and Redevelopment Authority, which manages several hundred units across, if not 1,000 units across the state, and also Fit New Horizons, which works with folks in emergency sheltering situations, transitional living, and then other pockets of providers across the continuum of social services. We're also working with our federally qualified health center, Amoskeag Health, and they're partnering with us to serve their clients. They don't actually receive a direct shipment of vaccine, so they're partnering with us, and they serve a very diverse group of folks that they can best serve, and we can partner with them to get the vaccine to them. Additionally, we're working with people of color, folks with linguistic isolation or that speak different languages, and different cultural partners, and we're meeting to look at setting up neighborhood level clinics utilizing either gymnasiums or school settings or conference settings to do smaller clinics with our partners. So we've been working not only on planning, but we've also been out in the community doing vaccinations. We've done about almost 800 vaccinations since the end of January, and we continue to schedule not only first dose clinics, but we also are responsible for second dose clinics. So we have a very busy calendar already booked well through March into April to get to folks either through a partner agency, and then we're also looking at, there are some folks that can't get to a site, and we are looking at different models to get the vaccine out to folks that are homebound, knowing that because they're not congregating, they're not at the highest level of risk in the immediate term, but we are working to best leverage resources. So just to give a little context, when we open a vial of the Moderna vaccine, they generally have about 10 or 11 doses. If we open that vial, we have 6 hours to use the contents. And so if we are going to a clinic and doing an estimated 60 people, and we're able to squeeze out extra doses because we're very careful with measuring. We have different standby lists that we are pulling from based on either first responders who haven't been able to get the vaccine or other partners that had barriers to registering in VAMS and can't get an appointment until April. Those types of things for our highest risk individuals are things that we're on a daily basis trying to shuffle and scramble to use every last drop of that vaccine.
Yeah.
And I'll say early on when the Guard was standing up their site, we were providing them, I think we provided over 120 individuals on a standby basis early on to make sure that none of those doses were wasted. And then we took on the responsibility of providing their second dose. So yeah, we have a lot of things in the queue. We are working very closely with our first responders. Manchester Fire has been amazing in providing EMT
They always are.
to provide not only with our testing, partnering with our staff, but also partnering with our staff to go out into different facilities and provide the vaccine. So it's all hands on deck. It's really great to work in a community where folks are just a call away from supporting you, and the sheer look of happiness in folks' faces has been so rewarding and re-energizing for me after a really long slog of people not wanting to hear from you when you're trying to contact trace and ask them questions. How did you get my number? It's been probably the best month, in a very long time, and
Well, I'm glad you're having a good month. I'm so glad you spoke about the issue of not wasting doses, because nothing more precious in the world right now, I guess, than an effective vaccine against the coronavirus. So how does somebody like me get to be on standby? How might I and my wife get a call, since we didn't exactly succeed in our effort to break the line and snoo this morning?
Yes, so our standby list is anybody who's still in 1A.
Okay.
So we use that priority. Once our 1A list is done, then we would start moving to 1B.
Okay, that would be good.
Yep, and so what we anticipate doing, and we've been getting calls from folks as some of our partners about people who are homebound. So we're devising a strategy to best capture that and include those folks and their caregivers if they have one. So we're really trying to stratify by if you're able to go to a fixed site, you should definitely
Bob,
keep
stop
your
trying
appointment.
to cut the line, Bob.
we're doing our very best to make sure that any doses are given to folks that have the least chance of getting them otherwise.
Okay.
I know that sounds a little
Well,
but that's our
Your
main
job.
focus.
That's your job.
I can't
Yeah.
quarrel
And by
with
the
those
way-
priorities, and I'm interested. There's still people in the 1A category that you haven't got vaccinated yet.
Yeah, for various reasons. Yeah.
Yeah.
I
Lack
will-
of
if you wanna
transportation,
get-
lack of knowledge, all those sorts of
It
things.
could be some hesitancy. They wanted to see their coworkers get it first.
Yeah.
Some of them are waiting for the Johnson & Johnson vaccine to get approved. Some folks have that we've worked with recently are medical professionals that had a medical reason that they couldn't get it right away, and now they can. So there's a whole host of different things, but we want to make sure that especially our first responder and healthcare provider partners are able to get the vaccine, because they really truly are at the highest risk of having contact. I just want to also mention that we are planning for 2A, which includes school personnel and childcare personnel. So we are working with all of the Manchester School District, and Dr. Gillis has been an amazing partner of ours to basically quantify an approximate number of how many folks are in the district that are less than 65 years old that can't already qualify, and how many of those folks would be willing to...
Where do I sign up for that list?
Let's take another call. We have another call.
Talk to Dr. Gillis.
Hey, caller, we're glad you're with us on the progress report. We're happy to get your question or comment for any of us.
Where do I sign up for that list?
Let's take another call. We have another call.
Dr. Gillis.
He's got to turn his
We're
TV
glad
down,
you're with
Bob.
us on the progress report.
I'm not sure. Caller, if you got your TV on, can you turn that down so we can hear you?
Yes, I will. Thank you very much.
Okay.
Let me just move away from the TV. That'd probably be the best thing.
I think that'll work.
How's that? Is that any better?
I can hear you loud. That's good.
Okay. My question is, I know you're talking about, people getting the vaccine and when they get it. I don't understand. I am in 1B. Okay, I understand they're trying to catch up with that.
Right.
I went and did that whole scheduling. Is it through VAM? Is that correct? Did you do that?
Yeah, that's what I did too. Yep.
Yes, and I do not have an appointment until the 20th of April.
Oh my goodness,
And
that's much later than mine.
I'm wondering, are these going to be moved up, or is that just what I have to live with? I mean,
That's sort of
it's
my.
a long time. I have three
Yeah.
comorbidities.
Oh my goodness, it sounds
I'm
like.
not 65, so that doesn't count. But as I said, I do, and the doctor did do the verification on that. I mean, does that seem like a long time to wait for this?
Does to me.
So
Does to me.
It does.
Let's
it's
let
not-
Phil
Sure.
respond to your question. I mean, if you've
Yeah,
got three
okay.
comorbidities and you're off until almost the third week of April, I mean that's.
Exactly. Yes,
all right.
That's what I was given.
All right, we'll let you go and you'll get your answer on the over the air.
Thank you so much. Have a good night, guys.
Thanks for calling.
Take care. Thank you for calling. So I think getting back to our previous discussion, the amount of slots that are available based on what is anticipated to come in for vaccine kind of sets how they schedule. So if we're only getting, 17,000 doses and there are 325,000 people who are eligible, at that rate, it makes sense, unfortunately, that there are appointments being booked into April, even though the phase says on all of the infographics, January through March. So the sheer numbers don't align with what people have been kind of conditioned for, which I don't have a good answer. What I can say is, if we were to get additional vaccine, or if the Johnson & Johnson vaccine became available, that might make it so that those later appointments could get moved up. I know that the state has moved second appointments up because they needed to get within the window of opportunity for the vaccine to be effective. I would instruct the caller to be paying very close attention to updates. I'm happy to come back onto the show and give an update before April so that we can, give that information out. And certainly, if the state is able to make more appointments available through those sites, that would be wonderful, especially if there's an increased supply. But I don't think it's out of bounds that there are appointments being booked into April for first doses.
I've just got to do a figurative blow top on that. I started the show talking with you about the need to really get moving. We're lagging now. We lagged. We took a whole year off, as far as I'm concerned, on this project, and we've only just gotten started. I mark January as the start of the real effort to defeat this virus, in my personal, frame of mind. But at this rate, where someone with three comorbidities, and then you're going to go down to the younger people, and you're going to have to bring in the teachers because we want to get kids back at school. There's no way. I'm not going to see a shot until 2022. There's no way. It's arithmetic. It's not even algebra. It's arithmetic. And I don't want to pit you against the state because I know you have to work collaboratively, but I've been seeing some of these interviews and they talk a lot about hope. And I was taught hope is not a plan. And the fact that they had to move forward second doses because they figured out that they were spaced too far out, holy cow. That to me is, whoever did that calculation ought to get out of the way and let someone who can count come into the chair. I'm not asking you to jump in and make the statements I'm making, but I'm asking you, what's the prognosis? Are we going to get better at this, or are we going to rely, because they're not getting the job done in Concord. It's not happening.
So I think what's important to know is to have all of the information, starting with how many actual doses are coming into the state at any given time. So at the very beginning, and currently we're getting just over 17,000 doses a week. So doing the math, as we talked about, that's going to take, up to 20 weeks of time at that rate to do 325,000 plus people.
It's just
So
one
just
dose,
that-
though.
That's so. I'll say the good news is when a dose is allocated, the second dose is parked so that it's guaranteed. Now, there's been debate about whether or not we should release all the second doses and do everybody's first dose, but there's no guarantee that we would then get the second doses to get them in the time that would make the first dose effective. So it's
And what you
it's
just said,
challenging.
I agree with you, but why not?
Yeah.
Why is there no guarantee that you can get a second dose? What's the, and this is a national problem.
Yeah.
I'm putting you way out of your,
I've heard all of these frustrations and ideas around how do we get the most protection for the most people that need it, and who's at greatest risk versus maintaining continuity of operations. And no matter how you slice it, there are going to be people who don't agree.
Yeah.
And the way I look at it is, of course, you have to look at morbidity and mortality. And if we can protect those who we know are at absolutely astronomically high risk compared to the general population, that's where the priority should lie.
We can agree on that.
Yeah, and so I'm hopeful
Guys.
the rate increases, and then we can look at the whole scheduling thing is a whole show in and of itself, and will be in my book someday. But essentially,
I'm looking forward to your book. Hey, we have another call.
Oh, great, super.
Whoops,
Oh no, they didn't like my answer, I guess.
I guess not. Caller, I'm sorry I missed you. I was just letting Phil finish up his thought. If you want to call back, we'll do our best to make sure we get you on very promptly. We would welcome you to call back in, and we'll be happy to try and get you as part of the program, because we do appreciate our calls. Well, Phil, you've given us an awful lot of good information here, and it's triggering some interest, obviously. Here's another subject. There are anti-vaxxers in the world, not just for this vaccine, but for other vaccines. We've had a number of very prominent people, like Robert Kennedy Jr., for example, come out against a whole bunch of vaccinations, which is, to me, astounding. So I'm wondering, is this a major problem with our program here? There's an awful lot of people like me want to get the vaccine as soon as I can, and I would hope sooner than I'm scheduled. An awful lot. But there are people who are saying, I'm not so sure about this. I don't know what's in that damn vaccine. What are you seeing on that, the refuseniks?
Yeah, that's another good thing to talk about. We are looking at even the uptake in some of the folks in 1A is not as high as you might expect it to be. I've seen some preliminary survey data from first responders that vary from 50 to 70% uptake, which doesn't get you to that 70-80% herd immunity if you extrapolate that into the general population. Reasons vary from some people are because the Moderna and the Pfizer vaccines are sort of a different strategy of a vaccine. They're actually quite interesting from a nerd perspective, if you will, in that these are little fatty globules that are surrounding a piece of instruction, some messenger RNA. So these little pieces of instructions are coated in little lipids or fats. They're injected into your body comes, sees these things, opens them up, sees the instructions, makes a protein, which is the spike protein from the COVID virus. I'm simplifying a little bit. Then your body's like, what's this? It says, I don't like this, I don't recognize it, I'm going to get rid of it. It gets rid of it. It tells your immune system, hey, if I ever see this again, we better get rid of it. And that's that immunity and that memory. How long that lasts is the $64,000 question, and we're not going to know that until we've looked at the folks that were in all the trials and see how their blood work looks from an antibody perspective down the road. So a lot of people are asking, well, do I need to get another COVID shot next year? And the answer is, we don't know yet. And people don't like that answer. But again, with something that's new, we don't have all of the answers. I think we've tried to be, at least me coming on the show, I've tried to keep saying things are going to change. You should be prepared for that. But those two vaccines are kind of it's not brand new, but it's new for, common use. I have a friend.
It's very interesting, Phil. It's not like the old vaccines where you'd get a dead virus or maybe even a small live virus, but that would trigger. This makes your body make a little piece that reminds it of the virus. It's amazing technology.
How about that?
It's amazing to think of. Phil, let me ask you a question, which is kind of coming off of people who are recovering from the virus, who have already had it, they've survived it, and they're back, or people getting the shot. Can they just say, okay, I am golden now. I don't ever have to wear a mask. I can never get any virus in me. I can never expel any virus on you. Because I'm encountering that in my day-to-day life where people say, I don't have to wear a mask. I can walk right up on you because I had it. And I'm nervous about that. What can you tell me about that?
Well, thank you for saying that, because that of all of the misconceptions, that one definitely needs to be messaged better and differently, or in a way that sticks. Just because you aren't going to get sick or significantly ill because you're protected against serious or moderate disease, which is what these vaccines are really good at, we don't know for sure that you cannot be infected and then infect other people. It's really the virus is protecting you against serious disease and hospitalization and death. It doesn't mean that you are not a potential hazard to others. And so that is a really hard concept to get a hold of, because while we have a vaccine that's going to help, prevent bad outcomes, it doesn't mean that we're free and clear. And that's why the social distancing and the face coverings need to persist until we get enough people vaccinated, such that there's not as much virus circulating, such that we'd have a less risk of transmission. And so that's the important message. Is it doesn't mean that I can just not follow all the rules. The only thing it does, if you've had your 2 doses and you have finished your 2 extra weeks, so your body has developed its protection, is if you're exposed to somebody, you're not subject to quarantine, because you are not going to likely develop the virus. However, that doesn't mean that you're free and clear to host large gatherings, which one of my colleagues showed me a very interesting little chart of a case who hosted an event that coincided with a certain big game that happened that one of our former players was actually in, so people had an interest in it, football game. Then that event precipitated positive cases, which then went to a different type of event, which then now has several contacts and several people who are ill. And so just because you have something in your house, I think I talked about it last time, doesn't mean that you shouldn't follow common sense protection measures. Even though it's it's in my house, it's not a big deal. I'm not having a big gathering. Doesn't really matter until we have enough people protected at a certain level. The virus activity is lower, the positivity rates are lower, such that your chances of encountering the virus in the wild, I like to say, or just out and about, are low enough that your risk is that much lower, and all of these protective factors are going to hopefully make it so that the virus has really no other places to go, and will hopefully stop messing with our lives. But we have work to do yet, and we need to make sure that we keep the trends in a good direction and take just like we incrementally tighten things up, we have to carefully and thoughtfully loosen things up when it's appropriate. And a 2-week window for me from a epidemiologic standpoint, which is the study of how diseases, we know the incubation period from the time you're exposed to the time you become infectious and sick is anywhere from 2 to 14 days. So using 2-week intervals to really look at, is this a blip or is this a reality, is important, especially as we look at, well, maybe we should do this and allow this to happen, and then what? And then take incremental steps makes a lot of sense. And I hope that we take a common sense approach and don't just say, oh, this expired on this date, so we're just not going to do this anymore, without really careful consideration, like some states are just saying, oh, we're done with the masks.
But isn't there some evidence, I thought there was some evidence that if you had your 2 shots for the ones we have now, or the one with Johnson & Johnson, when we get that, it does affect the transmissibility threat you may present somewhat, right?
Yeah, it should dampen that down. The extent of it isn't completely understood because we're still kind of evaluating your immune status after all these trials and people who are getting the vaccine. As we learn more, we can say, yeah, we're really confident that these vaccines are not only efficient and protect you, but they are also effective in preventing disease transmission. The Johnson & Johnson vaccine studies speak better about that transmissibility than the Pfizer and Moderna vaccines. So you may see that in the literature. It's hopeful that if you have strong immunity, your body is going to keep the virus down to a low level that would make you less infectious, but it's not a zero risk by any stretch. So wearing a face covering still is important.
Phil, this new Pfizer vaccine, it's a one shot. It doesn't have to be kept on the surface of Pluto temperatures.
You're talking Johnson & Johnson. You said Pfizer.
Oh, I'm sorry. Yeah, I misspoke. The new Johnson & Johnson, is that the same messenger RNA technical technique, or is that the older reduced virus technique of immunology?
Yeah, it's not the newer technology. It's a more traditional. I'm not sure if it's a attenuated or weakened virus, or whether it's just pieces of the proteins that they put in that make your body react. It's more typical that we're used to seeing. So some people that I've spoken with are more willing to get something like that than to something that was more novel. And we may see that. We're working hard right now to work with different community partners to better understand, the concept of vaccine hesitancy, whether there are cultural differences, whether there are sector differences, and what do we need to do to message, working with community leaders that may have mistrust in either government or healthcare or all of the above to better explain why this is important, so that people can make the most informed choice and not make their decisions based on things that have been told to them, for instance. And so we're happy to talk about our experiences. I'll be candid. I work in these clinics and testing sites, and fell under the 1A group and had both of my doses. I'm 1 week away from that magic 2 weeks. And I'll be honest, the second dose for a lot of people tends to be a bit of a doozy, so to speak, where some folks have spiked fevers, which really means your body is mounting a response.
Yeah, I was going to say, that's a good response, isn't it? That's what you want.
Yeah, exactly. So it's a little bit different because usually, at least in the typical vaccines that I've received, I don't feel, other than the really sore arm after a tetanus shot or something, more than that. This one is a little bit different. So we also will message to folks, that second day or the day after you get your second dose, you may not feel great. So we take the planning to the nth degree, and if we're out doing, police force or fire service or long-term care folks, we're saying we're going to stagger the second doses, so you don't have an entire shift of people who aren't feeling great. So we are like in that level of minutia to make sure that not only are we protecting people, but we're protecting the community by not having the workforce impacted.
Yeah.
One other group that I'd be remiss if I didn't thank are the pharmacy partners in the community. They stepped up through a national contract to bring the vaccine to our long-term care facilities. So the Guard has been amazing. CVS and Walgreens have been good federal partners to get the vaccine into these facilities, because moving folks with a whole host of different comorbidities would be a real challenge to send them to a fixed site. So there were really good decisions made about bringing the vaccine to those venues, which really helped us focus on our community response. So I did want to say that they've been great, and
That's good to hear.
They've been really, that's a positive
That's really good
note
to
as
hear.
well.
So, we are still not yet a full month into a new administration in Washington. And I don't want to get you going on politics, but this administration has made fighting the pandemic its number one priority. Are you seeing the benefits of that commitment from the new administration practically in what you're doing here?
So we, generally, things trickle down from the federal level, funding and things of that nature. For a while, we had a limited chunk of money to pay for some of our effort. We've seen some newer funding coming more recently that may have crossed over the two administrations. I haven't seen a discernible difference. We're kind of mulling over some new guidance that's come out. Certainly there's a lot of attention on the academic setting and
Right.
the school setting. A new document came out in the last day or so that we need to digest to look at, what makes sense for learning and with our school partners at the SAU. So we'll be involved in some of that work. But from a practical standpoint, I haven't seen anything trickle down to our level that's different. I think we'll see if the vaccine flow increases. The approval process should be apolitical anyway, so
Should be.
hopefully we'll get that information, in the near future. And I think ultimately the question is, does the state and do local communities get what they need, and businesses the support that they need, because we've been asking everyone to make sacrifices. I often think that it's the little guy, that needs that support to keep their business going. And whenever, my personal philosophy is, if government needs to ask a business or an individual to make sacrifices, they shouldn't be done without some level of assurance, that on the outside of things, or the outset, that things are going to be supported. So I want to make sure, I hope that there is support for communities at the Main Street level and businesses, because everybody is really, it's taken its toll, and we need to hope that support comes and it's equitable across the board, not just for one sector or another. So that's me pontificating a little bit, but I feel very strongly that when that has to happen, and we don't take our public health police powers if someone's being asked to isolate or quarantine, which we did a lot of early on to try to stop this from exploding with a limited impact. If we ask somebody that you need to stay home for 10 days, 14 days, 24 days, however long, we have an obligation to make sure you have what you need. So we set up a hotline very early on for Manchester residents that if they were under isolation or quarantine, this weekend we were getting food for a family that needed to isolate but had no food, and this was on a Saturday and a Sunday of a long weekend. We're in this every day, every hour, all hours, and we'll continue to do so because the need is there. And I think what we'll need to think about as we return to normal are the things that we talked about before the pandemic, like substance misuse and mental and behavioral health.
I wanted to get into that whole subject with you, but we'll have to have you back.
We don't
This
know
whole hour is
the
flying by.
impacts there. and we cannot lose sight of what everybody has gone through and their collective experience.
Well, they say it was the wettest dry January in recorded history. I mean,
well, that's good for the tax base, I guess, for New Hampshire.
Well, we can chuckle about it, and everybody does what they need to do, but there are lines that you can cross, and it can mean lives. So I'm very happy to see that you're not forgetting about these other issues that come right along with everything else.
I mean, we had our plate full with people experiencing homelessness and mental behavioral health that ties right into that, and substance misuse, which it's all tied together. These are big system issues that we had on our radar and our community partners did, and we have folks that will not allow that ball to be dropped, and are trying to get back to that work now, knowing that there are lots of impacts that we won't know, and like any long stress event, we're going to need to be ready to respond.
Yeah. Gee, we're almost at the end here, Mike, and I got still a whole bunch of things. I guess we're going to have you back, Phil, but
anytime. I'm happy to come back.
Well, you're just a great guest. We get so much out of your knowledge.
Yeah, these are like going to school.
I guess I'll just ask you,
No
what are you now advising the Manchester School District about, return to in-person education? And if you can just touch on it, it's the other encouraging thing beside the fact that we are actually getting vaccines into people's arms is the drop in new positives, the drop in hospitalizations. That's got to be making you smile. And we only got a couple minutes, so whatever you want to touch on, we'll be glad to get.
Sure. So we have a great relationship with the school district. We meet several times a week, and we work with the district and the school board to look at, early on we put together a series of indicators collectively that would kind of describe what we knew at the time to be levels of risk and actions that should be taken, but not only levels of risk, but also the things that we could do as a community to mitigate the risk. So it's not a one-dimensional, if you hit this number, this action must happen. In fact, the CDC's new guidance speaks to that. And I think it's also important that anytime you create something from scratch, it's going to need to be adjusted and looked at on an ongoing kind of quality assurance basis or for improvement. So the Matrix, if you will, people call it the Matrix, not to be confused with the movie series, but has a dashboard of indicators that talk about community factors and risk. But it also is coupled with what is in place in the school setting. So we had worked together to look at ventilation and filtration and isolation space and all of these things and disinfection products. So we've been working on this from the get-go, and we have a lot of those mitigation factors already in place. So bringing more students into the school setting, but really being very careful that we still have the capacity to do contact tracing. We feel very strongly that, we need the most current data to drive decisions.
Yep.
So if we are not able to keep up with the caseload, we wouldn't really know in real time if we have a problem in any given school.
Yeah.
So we're working very closely with our school nurses who work for the health department, but are that sentinel indicator for things that are happening in that setting. And
certainly a vital part of our public health.
Yeah. So we're
public health
definitely
system, our school nurses.
Keeping informed and working with the schools.
We're out of time. Phil, thank you for joining us. I wish you were here with me, but you were a great guest on Skype. Mike,
Hey,
it's
Bob.
always a pleasure.
Bob, can I quickly just point out that we're coming to the end? We had Valentine's Day, Washington's birthday, Mardi Gras, and today is Ash Wednesday. 4 holidays in a row, man. I don't think we can take it. I just wanted to point that out before we end the show.
And I appreciate you making it Washington's birthday, not President's Day. I'll never buy a car from a dealership that has President's Day sale. I never will do
Phyllis,
it.
great talking to you.
Likewise,
Take
guys.
care, guys. It's been a pleasure.
Be well, everybody, where you're at.
Yeah.